Hello, my name is Stuart Feichtinger. I'm one of the dual critical care cardiothoracic anesthesiology fellows, and I'll be talking about ultrasound-guided central line placement. So this is a quote I really liked from one of my attendings in residency, Dr. Cummings, and he would always say, just because there's an ultrasound in the room doesn't mean it was ultrasound-guided. So this presentation is targeted at folks who know the steps of an out-of-plane ultrasound-guided central line placement. If you don't know those steps, that's okay. Check out the New England Journal of Medicine videos or something similar to kind of just see the general steps. But really targeting the folks whose skills have plateaued and you're really not sure why. Like the easy lines are easy, pretty quick at those, but the hard lines are always hard. And sometimes you find you can struggle. And sometimes that can be frustrating because you watch these videos where it seems really easy. You see you put the needle just directly in the vessel, but when you try, it doesn't seem to go quite as smooth as that. Or maybe you do get into the vessel, maybe you do get some flash of blood, but then you just can't thread your wire. So we'll talk about kind of optimizing your central line approach today, and specifically really nailing down that ultrasound guided. Objectives today are going to be kind of rational target vessel selection, how to pick between the jugular, femoral, subclavian. Improving probe control, which is really going to be the most important thing I bet will really bring most of your central line game to the next level. And then improving needle tip visualization, emphasis on tip, and specifically in the out-of-plane approach. In-plane or long axis is a totally valid and great technique. We just really won't be touching on that much today. But then we also will be talking about confidently accessing your target vessel. Kind of once you have flash, how do you bring it home and getting the wire in? So I like to break it up into assisted and guided. I think assisted is an extension of the landmark technique. Pretty much find a large vessel and stab underneath the probe. I think this is characterized by poor probe control and big and fast movements. The vessel always seems to be moving across the screen. You're constantly chasing after it with your needle. You never really see your needle well. And again, easy vessels are easy and hard vessels are always hard. So hopefully we can get to more of a guided approach, a truly guided approach, where we're going to systematically evaluate our vessel and choose that specific entry site. We're going to have precise probe control with slow and controlled movements, and our vessel is going to stay fixed on the screen. We'll have precise tracking and placement of our needle tip. And if you can really master this, you'll find that there's a lot fewer hard vessels out there. So for an example, on the left here, this is what I would say would be something like an assisted approach, where the vessel's moving all over the screen. You don't really see your needle. Maybe you see some tissue indentation, but really don't really have good tracking of your needle tip. If you look at guided here on the right, this is more the approach that I think really you try to aim for, where you have slow, precise movements. The vessel stays still. You find your needle tip, advance it down, and you enter exactly where you want it to be. You know exactly where you are. You know exactly where your needle tip isn't, and really have this precise control. If you can place your needle tip anywhere you want it to, then again, it really doesn't matter if the vessel's big, small, whatever. If you can put your needle tip where you want it, then you can get it where you need it to be. So vessel selection. In general, most of what I'm going to be talking about applies in terms of technique, applies to any of your major vessel sites, femoral, jugular, subclavian. But either way, any of those, you're going to see a paired artery with a large vein, and the vein is going to be collapsible. The classic central line placement options are going to be jugular, subclavian, and femoral. And we'll talk a little bit about the pros and cons of each one of these spots. So this is kind of one of the big landmark trials. It's called 3 sites, which compared in a semi-randomized way complications among the different major sites. So they looked at subclavian versus jugular versus femoral complications. So they started off looking at bloodstream infections, kind of the CLABSI we all know and fear. And so what they found, subclavian in this study had the lowest rates of central line associated bloodstream infections. Interestingly, despite kind of the common thought process of the femoral being a higher risk of infection than jugular, in this study specifically, they didn't really find that, with similar rates or maybe a little bit higher with jugular. Either way, the subclavian was the lowest. And then for DVT, kind of a similar pattern with subclavian being the lowest risk of DVT, femoral having the highest risk here. And the final category was mechanical complications, really where the subclavian had the highest risk. For this study, the mechanical complications were defined as a composite outcome of a pneumothorax, hematoma, or arterial injury. Notably, though, while in this study, jugular and femoral were largely ultrasound guided, the subclavian group here still was mostly landmark. So another study came out, kind of comparing the real-time ultrasound-guided subclavian versus landmark approach and kind of the complication rates of that. Look at a number of different outcome measures. But few notable ones were the success rate was much higher with the ultrasound group in this study. Arterial puncture was fairly low, or was lower in the ultrasound group than landmark, as was hematoma and pneumothorax. In this study, they didn't have any pneumothoraces in the ultrasound group. And these 3 together, again, remember, comes back to the composite mechanical complication outcome in 3 sites. So we kind of Frankenstein these 2 studies a little bit and put them together. If we look at the complication rates among the subclavian group in 3 sites and kind of extrapolate our information from the other study with ultrasound guided, we've actually found a similar mechanical complication rate in terms of a composite outcome, but more so that with hematoma and arterial stick. And there was no pneumothoraces in this group. I guess this isn't terribly surprising about the increased risk of hematoma compared to the other 2 sites, given the difficulty or impossibility of compressing subclavian vein given its proximity to the clavicle. So kind of in summary here, our vessel options, we have our subclavian, which seems to have the lowest CLABSI rate. This is actually UW's preferred CVL site. If you look in the policy, I think it's mostly just because they track collapses and they don't track pneumothoraces. But either way, it is a good option. However, I would be careful in somebody with a bleeding coagulopathy, as this does have the highest risk of hematoma, and you can get into trouble because you're not able to compress it. And low risk of pneumothorax with ultrasound. This, interestingly, is actually lower rate of pneumothoraces than even those associated with a blind NG or OG placement in an intubated patient. Femoral is a good option, and it does have the highest risk of DVT, though the risk of lowest rates of mechanical complication and the risk of infection may be just a touch overblown compared to that of the jugular. I will say from an ICU standpoint, in a perfect world, I'd prefer not having a femoral line just because it can impair significantly the mobility of the patient kind of down the road. But in the moment you need access, and that's what you can get, and it's a lot better than nothing. So, but still my preference, if I can get something else, I usually will try that for that. But again, if that's all you can get, that's all you can get. Jugular, kind of the risk somewhere in between, actually similar rates of central line associated infection as the femoral. Lower risk of pneumothorax, especially if you don't do ultrasound-guided, than the subclavian. So that kind of gives you the pros and cons of the various sites for access, and I wouldn't say necessarily that one is better than the other. They each have their pros and cons, and they all have a valid role, I think, in central line placement. So moving on to probe control. This is kind of one of our critical areas, I think, and it's really one of those things that can make or break your central line game, I think, where a lot of people struggle. This is something I see commonly. I call it joysticking, where you're holding the probe up off the patient. Don't do that. So there's no way you're going to get precise probe control holding a probe like this. You can see that my hand is far off the patient. I'm just kind of hovering in midair. You're not going to be able to move precisely, and you're going to be putting way more pressure on the patient than you should be and obscuring your view. Proper probe control or probe position is holding the probe with your hand firmly anchored on the patient, your hand firmly anchored to the probe, and the probe kind of lightly on the patient. I tell my residents on the anesthesia side, if they're up overnight and don't have anything going on and kind of bored, and they have an ultrasound, one good way to know that you have adequate probe control is if you can have a friend and you can put that probe on there and put a vein or an artery or something random on the middle of the screen. If you can pull your cell phone out of your pocket, look down at it, send a text, and put it back in your pocket, and if you look back on the screen and the probe hasn't moved or the vessel hasn't moved, you're doing a good job. And that really, it sounds kind of silly, but that's really critical. I don't know how many times I've seen people when they get the vessel on the middle of the screen and they're about to numb the patient before they do a stick, they grab their lidocaine, they look down at their hands, they inject the skin, and they look back up at the screen, and all of a sudden the vessel's all the way off the side, and they numb the wrong area. So really being able to have this probe control where the vessel doesn't move unless you want it to is absolutely critical. So again, hand firmly attached to the probe, hand resting on the patient, probe lightly resting on the patient. In an idealized world, you would have the probe kind of hovering or off the patient with a layer of gel in between the patient and their skin. This is not exactly realistic. You are going to have the probe on the patient a little bit, but it's definitely going to be, it should be a lot more similar to what's on the left than what's on the right here. You really don't want to be pushing down terribly hard, especially when you're trying to do venous access, and especially if they're hypovolemic, because you're quickly going to find that your target vessel is going to be a lot harder to stick, and it may just disappear completely. You can see here in this video, previously large vessel is now very, very collapsed when they're pushing down with the probe. And that's not uncommon at all. This is critical in hypovolemic patients. Not uncommonly, I will do a line in a patient or either peripheral IV or a central line where other people have struggled and the patient's very hypovolemic. And it's usually they have really small target vessels or they aren't finding anything for like a peripheral IV. And then when I try, I just gently rest the probe on the patient and I have all of a sudden these big targets that other people could hit. It's just they never saw them or made their targets a lot harder to hit because they're pushing too hard. It's a really low-hanging fruit in terms of making things easier for yourself, especially in the hypovolemic or hypotensive patient. All right, so now talking about needle tip visualization. So this is absolutely critical in the short axis out-of-plane approach. The out-of-plane approach, you're really going to get a cross-section of your needle tip, of your needle, I should say. So if you have the beam over the needle tip, you're going to see a dot. If you have the beam over the middle of the needle, you're going to see a dot. So the only way you know that you are at your needle tip is if you move the beam past the needle and the tip disappears, or the dot disappears. That means you're now past the needle, and then you come back. So as soon as you hit where you're getting the dot back on the screen, that means you're at your needle tip. So this is absolutely critical when you're doing an out-of-plane approach, is you're constantly going to be playing kind of a hide-and-seek game with a needle tip. You're going to be going just past it with your probe until it just disappears and then advancing your needle so it comes back on the screen. Again, absolutely, absolutely critical. In the in-plane approach, where you have your needle visualized the whole time, you don't move your needle unless you can see it. In the out-of-plane approach, you don't move your needle tip. You don't move your needle unless you can't see it. But you should be advancing just into that beam so you always know where the needle tip is. Can everyone see my needle tip here? Here, I'll jiggle it. You can see that nice bright dot right in the middle of the vessel. Looks great, right? Well, we never actually saw it disappear. So let me go into long axis here and take a look. So that was not my needle tip. That was the middle of the needle. So you can see the needle tip is through and through the vessel. And this is actually how you can stick a carotid or dilate a carotid on an ultrasound-guided approach, is if you never actually know where your needle tip is and you just jiggle the needle and you see something moving and assume that's your needle tip, that can get you in trouble really fast, especially in small vessels with close proximity of other structures. So if we actually go back to the short axis here, now I'm going to follow the needle tip down, or follow the needle down I'm going to move the probe forward and forward and forward until that bright dot disappears. So that was my needle tip. That's how I would know that was my needle tip in the short axis view, by going past it until it disappears. Then I bring the probe back, it reappears, and it's right there. So that's how I would have known that was a needle tip. All right, another really critical point has to do with what's called the angle of incidence or angle of inclination. And this has to do with the angle of the needle compared to the angle of the beam coming from the ultrasound. So if the needle is perpendicular to the ultrasound beam, your sound is going to go down, hit the needle, and come right back up, and you're going to have a very bright white needle tip, as the vast majority of that sound energy is going to return to the ultrasound probe. However, as the needle increases in steepness and the angle of inclination decreases, then more of that sound energy is actually going to be reflected away from the probe, and your needle tip is going to become less visible. As you get to an extremely steep angle, then you may have the vast majority of that sound energy being reflected away. And so you might encounter this as if you have your needle entry point, like say right next to the probe. That's going to make you a very steep angle. This is, I think, a really critical thing to know, as I guess in a perfect world, you would try to stay with a very shallow angle and being perpendicular to that beam of sound. However, if you have a deep vessel that you're trying to access, you're never going to be able to reach it if you're always staying at a very, very shallow angle. And so by knowing your relative angle compared to that beam of the ultrasound beam, you can kind of calibrate what you're looking for on the screen in terms of, are you expecting a bright white needle tip because you've got a pretty close to 90-degree angle, or are you very, very steep, and then now you're not expecting to see a bright white needle tip. What you're looking for is just a shadow or maybe some subtle tissue displacement. So again, kind of to reiterate that, we have our 90-degree angle, we're going to have a bright white tip. As we increase in steepness, we're going to get progressively harder to see. So here's a video clip showing kind of an example of this. We have the ultrasound in the upper right corner. You never really see the needle, but you can see this person has gotten flash in their syringe. And you can see that they've entered the skin right next to the probe, so they're at a fairly steep angle. And again, really there's no evidence of the needle. Well, there's minimal evidence of the needle here up on the ultrasound image. Kind of some more, to kind of bring this point home a little bit more. This is actually the long axis view, but you can see that this needle is somewhat hard to see. And some clever people out there have tried to make devices and techniques to improve the visualization of this needle, but it really comes down to getting that angle of inclination or angle of incidence back to 90 degrees as best as possible. So if you've ever heard of like an echogenic needle or these easier to see needles on ultrasound, really all those do is they have fancy notches or steps kind of built into them that try to reapproximate that 90-degree angle as the needle itself is actually more at like 45-degree. Also, some of the fancier biopsy ultrasounds or something that my IR might use actually can do something called beam steering, used a phased array. But again, all that's doing is trying to reapproximate that 90 degrees to give you a bright white needle and easier to see. Just a really quick tip, kind of a quick commercial break here. I'm keeping track of your bevel. So if you put the needle on the syringe with the bevel facing up and the numbers of the syringe facing up, and that way, even if the needle is in the patient, the needle tip is in the patient, if you can see the numbers of your syringe, you know that the bevel is up. Another bonus tip here is that you really don't want to over tighten the needle on the syringe. So a little bit of foreshadowing here, but one of the common ways that people screw up a central line or aren't able to thread the wire is once you've accessed the vessel and have flash, is as you're trying to take off that syringe. If it's on there really, really tight, you can get a lot of movement as you're trying to force that syringe off, especially if it's a small vessel. So you really want to be very careful and just have it on barely tight when you put that needle on the syringe. So kind of putting it all together, let's go through kind of the process of doing a central line. When you first pick up the probe, you always want to do a sanity check to make sure that left is left. If the room is a little dark, it's hard to see that dot, or especially after you put on the probe cover, it's going to be really hard to tell which side the dot is on the probe. And I promise you, if you don't check this, you will have a number of times where you'll really struggle, and it'll take an embarrassingly long time to figure out that your probe is switched, and that left is right and right is left. So to this day, whenever I pick up a probe, I always touch one side to make sure that left is left. So the first thing we're going to do is coming back to, we really want the vessel to stay in the middle of the screen, so we're not chasing it with our needles. We do a pre-scan survey. This is also going to evaluate the vessel to make sure that it's patent, there's no clots, anything like that. So what we want to do is we want to run our probe up and down the vessel. And as we do that, we really want it to stay in the middle of the screen. You can see here that it's moved off to the side. So as we go, if we're not in line with that vessel, it's going to move closer. Well, the probe side is going to move closer to the vessel, and it's going to appear to go from side to side. So we want to be able to find an orientation of that probe that as we move it up and down, that vessel is really going to stay in the middle of the screen. You can kind of think of the vessel as a railroad track and your probe as a train. We really wanted to have it staying perfectly over that vessel so the vessel stays in the middle of the screen, and that way you're not chasing after it when you have a needle with your needle tip. This can actually be a little bit frustrating at first, especially if you don't kind of have that muscle memory of how to automatically adjust. But it's really something I wouldn't rush, and I would really make sure that I could do this easily every time I do this with a patient. I make sure I can, because I promise you it's not going to get easier once you have that needle in their neck. So a little trick, if you're having a hard time and things are just not clicking, and no matter what you do, it seems that the vessel is running off to the left or the right, one thing you can do is kind of in your head make an imaginary X, kind of closer to you where the vessel's in the middle of the screen, and then just move the probe up, and if it moves off to the side, that's okay. But just put the vessel in the middle of the screen down wherever you are, and then draw an imaginary line between the two, and that can kind of help orient you to make sure that you are on the right axis. So this is a really important line here, the line of the vessel. You really want to be kind of everything in line with this. Behind the patient's head here, I want to be standing with my shoulders square to the probe so that I'm not off to the left or right. I want to be really shoulders kind of, again, parallel to that probe. And my needle is going to be entering the patient kind of directly in the middle of the probe. So again, I'm going to be moving along this line, and then out towards the patient's feet I want to have, or off to the side I want to have the ultrasound screen so that I can just look up and down and I'm not turning my head to the left or the right, just everything along this plane here. So here's me running, doing a vessel survey. You can see on the left that my hand is moving fairly slow, but on the screen, it seems to be moving pretty quickly. So this is about as quick as you want to move. And when you actually have a needle in the patient, you're going to be moving even slower than this. You can also see that my hand is braced on the patient with my pinky finger kind of resting. And I'm really moving the probe up and down just with my thumb, index, and middle fingers there. I want to be very, very well braced. Again, I should be able to look down. I should be able to pull a phone out of my pocket. I should be able to look all over. And when I look back at the screen, the vessel should still be in the middle of the screen. So now we're going to put it all together. We have done our pre-vessel survey, and now we're actually going to try to access the vessel. So our focus here is really going to be picking a needle entry site, and again, needle tip visualization is absolutely critical. So here we are. We're going to do our pre-scan. We can see that our vessel stays in the middle of the screen on our ultrasound. Then now we're going to pick our entry site. So some people might try to enter the skin right next to the probe. I'd recommend not doing that routinely, especially with a vessel that's fairly shallow, like 2 or 3 centimeters or less. But really more, I like to pick an entry site that is about the same distance away from the probe as it is deep, because that's going to give me a needle trajectory of about 45 degrees, which will give me a reasonable visualization of the needle tip, while also allowing me to get deep enough to access the vessel. If you're going after a vessel that's very deep, like potentially like a subclavian or something, you may not be able to go back 5, 6 centimeters, but by staying back at least a couple centimeters or a little bit farther if you can, it will increase the needle tip visibility. And if you're unable to do that and you have to enter the skin closer to where the probe is, then just realize that your needle tip is not going to be nearly as easy to see. In terms of entering the skin, left, right, or center of that the middle of the probe, I would really recommend entering kind of dead center of the probe. So your goal is to be right over the target vessel, the straight down trajectory. Sometimes, especially newer folks, they see the artery over there on the left and they're really worried about sticking that, so they stick the needle in the skin on the opposite side of the artery. I would really strongly recommend against doing that, because if you look at the trajectory you need to take to get to the vein, you aim right at the artery. I would highly recommend that you try to aim for the center of the vein and go straight down. However, if you're going to cheat one side or the other, I would actually say cheat artery side, because that's going to give you a trajectory away from the artery. Again, I would say aim towards the middle and go straight down. But whatever you do, don't cheat on the opposite side of the artery, because you'll end up aimed right at it. All right, so we've done our pre-vessel scan. We've got our target entry site. Now we get our needle through the skin. This can be a little challenging, especially with floppy skin, and we want to hold tension. So if you have your probe hand resting on the patient, you can actually use like the hypothenar eminence of your hand to pull traction on the skin while it's also holding the probe, which is another bonus of having your hand resting on the patient with the probe. But okay, so we've gotten through the skin with a nice 45-degree angle. But again, that should give us reasonable visualization of the needle. But if we wanted to see the needle tip very well, we would be more at a 90-degree angle. So what I usually do here is I drop the angle of my needle, which to make that 90 degrees or close to, and then I'm going to bring my probe back to find that needle tip. And I should have a fairly bright white needle tip to find here. And that's going to give me that nice angle of incidence to where I can see a good visualization. So now I know where I am and I know where I'm starting. So I'm going to bring with the needle tip in view, I'm going to bring my needle back up to the angle I'm going to be using to access the vessel, and I'm going to be watching that on the screen at the same time. So now I know exactly what my needle tip looks like, how bright it is or how not bright it is, but at least I know the signature of what that's going to look like. If you do this technique, especially early on, I'd recommend really making sure, even look down at your hands after you do it, that you get the needle angle back up again. So if you start low, like I suggested here, and you aren't paying attention, sometimes you can think that you increase the angle of the needle back up, and you never really do, and then you stay a lot more shallow than you meant to and run out of needle. So the first few times, if you do this technique, you get through the skin, drop your angle, find your needle tip, but really pay attention when you bring the angle back up. Make sure that you're getting back up to like a 45, because that's one of the areas I have seen people trying this technique struggle a little bit. But if you just pay attention and make sure your angle gets back up, you'll be fine. Okay, so now we know exactly where our needle tip is. We know our starting point. So now what we're going to do is kind of play the hide and seek that we talked about earlier. So I'm going to bring my probe forward. I've lost the probe or the needle tip, and I'm going to walk the needle tip down. So again, I'm going to just lose the needle tip, so it disappears, and then I'm going to advance the needle back into the view there. So again, a lot of the needle visualization isn't so much that you're getting a bright white needle tip. You can still fairly easily find a needle tip that is subtle or just a little bit of a shadow. If you know the exact square centimeter on the screen you're looking at, you're not scanning up and down the neck frantically looking for this needle tip. And so it's really critical kind of once you started this process where you're marching down to the vessel that the probe does not leave the patient. You don't break contact with the skin. You don't put it down, because if you lose your needle tip, and once you're kind of at this point, it's almost sometimes, especially early on, better to kind of go back to the start and retry again. Because again, it's easy to follow a needle if you know exactly where you're looking. It's hard to start from scratch to find a needle in the middle of the neck somewhere. Okay, so now we've gotten almost to the vessel. So it's kind of a next phase is to actually access the vessel itself. Once you get the needle at the vessel, you'll see tenting. Before you actually enter the vessel, you will see tenting of the vessel itself. You may actually see the needle tip right at the vessel, but not infrequently. You'll actually, the needle tip will kind of disappear at this point. And so really I'll use the tenting itself as my target of where the needle tip is. So kind of the same idea of the hide and seek. The same thing here. I will move the probe until it disappears, come back, and just keep looking for that tenting. And that's how I know where my needle tip is, even if I can't see it at this point. So now I'm ready to actually access the vessel. So I'm going to advance my needle. It may be, at this point, especially early on, it can be a little bit of a struggle, because if you're hesitant or a little bit slow, you're trying to slowly advance, commonly you can just collapse the vein and never actually enter it. So really you want to make sure that you're steep enough here. And also sometimes you need to do just a little bit, I don't want to say the word aggressive, but you got to kind of commit to getting through that vessel. So really, make a half a centimeter, deliberate advance to try to get through that vessel and kind of pop through. Again, we're talking like half a centimeter or so. You don't want to go through and through, but you really have to be kind of decisive at this point. Otherwise, you can just kind of slide across the top or just collapse the vessel and not actually enter. And it can take a couple of these to get comfortable with that, but it's not as bad as you think, and you'll quickly get a feel for it. But all right, so we're ready to actually enter the vessel. So I can't really see my needle tip, but I do see where I'm tenting. So now I'm going to advance my needle. And what I'm looking for is I'm going to see that tenting go away. And then commonly you'll actually see kind of the inverse where it kind of peaks up a little bit. Maybe not, but definitely the tenting will go away. And I will also expect that I have flash in my syringe at this point. So my next step is many people will try to immediately thread the wire right here because they've got good flash. But I would suggest not quite doing that just yet. And we'll talk about that in just a minute. At this point, though, I will follow my needle tip all the way down so I know exactly where I am. So just a really quick aside here. You notice that in these clips I've been showing that I've been doing a slide technique where the probe remains the same angle as the skin, and then I'm just sliding it down the neck or wherever I am. And I think that's a good approach to do because it does give you a reasonable angle of incidence or incidence, so that you should have hopefully an easier time seeing your needle tip. Again, it's not going to be as bright as if your needle was flat. But you may see some folks, instead of doing a slide approach, they'll actually do more of a fan. And I would actually, if you're having a hard time finding your needle tip, I recommend this not be your primary approach. If you do this already and it works for you, it works for you. But you can see that as I fan the probe down so that my beam goes forward and I can follow the needle tip, you can see that the angle of incidence is really going to steepen up, and this will progressively make your needle tip harder and harder to find. It's still totally doable, and as your skills improve and you're able to have that precise probe control, it may not be an issue, and there may be times when this is what you have to do, especially if you're really close to the clavicle. But I wouldn't recommend that be your default, especially early on, or if you have a hard time with finding your needle tip. Conversely, you can actually cheat the probe forward a little bit to really try to get closer to that nice 90 degrees. And so I will use this technique sometimes if I say I have lost my needle tip and I'm really having a hard time finding it. By cheating my hand forward and tilting the probe away from me, I'm going to get that better angle, and then I can use that hide and seek technique to kind of, again, try to find. You can use this technique to do this all the way to the vessel, which is totally valid. But one problem you may notice, that especially if you're up doing an IJ, is that the clavicle kind of impedes your ability to bring the probe far enough down and you aren't able to chase it. So you may have to actually go back up straight. But if it works for you, it works for you. At the very least, I think it's a good trick to have in your back pocket if you do lose your needle tip and you're trying to find it again. Here's just an image of somebody. You can see that they have cheated that probe away from them to try to re-approximate that 90-degree angle. Again, pay no attention to how they're holding the probe. Don't do that. But you can see the angle there. Okay, so now here's a clip of me, and we're going to go from kind of skin to just about where we're ready to poke the vessel. So you can see it's a little bit hard to see, but my needle tip is entering the skin of this dummy here about the same distance as the top of the vessel. I'm going to get through the skin, keep my angle very shallow, and I'm going to bring my probe back. Now you can see that bright white needle tip there. So now I know where I'm starting from. So now I'm going to bring the angle of my needle up. So I'm getting ready so I can have a nice trajectory to get into that vessel. So now the angle of my needle is up. So I'm going to get ready to enter the vessel. I lose my tip. Now I advance my needle into view. You can see that the vessel is tenting. And now it's rebounded, and I'm into the vessel. All right. So now we've got our flash. So what's our next steps? So let's talk about successfully accessing the vessel now that we have the blood returned in our syringe. So again, like I said, many people will try to thread their wire at this point, but there's some common problems that you may run into. One of them is going to be losing blood return when you disconnect the needle from the syringe. Like you had great, blood return as you're trying to aspirate, but as soon as you disconnect that needle, the bleeding, it's not bleeding anymore, or you try to thread your wire and it just doesn't go. Again, not being able to pass the wire, so this can be caused by what we just talked about, or it may be that your needle is in the vessel and you're just hitting the back wall with the wire. So how can we improve the chances of success once we have our flash in our syringe here? So I'm going to talk about something called the vanishing bullseye technique, or also vanishing target sign, you may see. And so this is a technique you can do once you're actually in the vessel. So what we're going to do is we're going to advance our needle a little bit farther, even though we have flash. We're going to see our needle tip. It's going to go down towards the bottom of the vessel on our screen. As we advance it, we don't want to back wall or go through the vessel. We're going to go advance a little bit more, and we're going to see something like this. At this point, we're going to do that bullseye part. So we're going to put that dot in the middle of the vessel, making it look like a bullseye. So that's going to involve dropping our hand and putting that dot in the middle of the vessel so we have our bullseye. So now we're going to make it vanish. And to make it vanish, we're going to move our probe away from us. We're going to go forward a little bit, a couple millimeters or so. And we're going to do the same thing again. Make that bullseye. And then by bringing our hands back down again. Kind of do this generally 2 or 3 times with the goal. You've gone far enough. If the needle hand is now dropped the angle so much that that needle hand is resting on the patient. So this may take 2 or 3 times. So why do we do the vanishing bullseye technique? So here's a couple of advantages. Here I'll show you a quick video of me doing this. Again, through the skin, I'm at the vessel. Follow it forward. I'm about to puncture. You can see I had the tenting there, and now it's kind of rebounded. You can see it rebounding. So I'm through the vessel, so now I'm going to follow the needle tip down. There's my needle tip. And then I'm going to advance forward, and then I'm going to drop the angle of my hand, making that bullseye. Advance forward, drop my hand, making that bullseye there. So if you look, see how my needle hand is dropped, and so to the point that the hand that was previously holding the probe, I can now rest firmly on the patient, and I can pinch the needle between my index and middle finger while having my probe hand secured onto the patient. I didn't put my syringe on too tight, so it's very easy to take off. So as I take off my syringe, I can now easily and immediately cover that needle with my sterilely gloved thumb. So this is going to prevent any sort of air embolization, and then also it's going to make it a much cleaner procedure. You're not going to have bleeding everywhere. And the entire time, though, because my left hand that's holding the needle now is resting on the patient, I should minimize any movement that occurs as I'm trying to move that syringe or before I get the wire in. However, let's just say I end up getting some movement even though I had my hand braced. Just compare the amount of wiggle room that we have for the needle to move before we run into trouble. So here we are between a steep and a shallow angle. So don't do this, but if you look, I don't have that much wiggle room before that needle goes all the way through the vessel when I'm steep. However, if my angle is shallow, like after the vanishing bullseye technique, I do have a lot more distance to go before that needle actually goes through the vessel. So it just gives you a little bit of margin for safety. It also gives you a nice demonstration of how the visibility of your needle changes depending on the angle of your needle to the probe. Let's say you have a steeper approach and you didn't back wall, but now you're trying the needle's firmly in the vessel, but now you're trying to thread the wire and you're running into trouble. So why is a shallower approach maybe a little bit better at times? So if we look, my needle tip is in the vessel with a steep approach, but even so, the wire still doesn't want to pass because it's hitting onto that back wall. However, if we use that more shallow approach, we're going to get more of a margin for error here because the wire is going to come out and it has a trajectory similar to the vessel. It's going to be more parallel or closer to parallel with the back wall of the vessel, and it just is going to generally go much easier. So again, if you have a technique that works for you and you're able to do it steeply and have good results, that's fine. But if you're finding that you're having problems or you're having difficulty threading the wire, this is, again, a nice technique that reduces the risk of that happening. Another little quick tip here, feel rhythm. So I'm an anesthesiologist by training, so I'll find any excuse to turn on my pulse ox beeps. It makes me feel better. But I would recommend that you turn them on during your central lines because as you're advancing your wire, if you go a little bit too far and you get some PVCs, you'll be able to immediately hear that without depending on others telling you that there's active P. So this can be very useful. If you hear that steady beep, 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 and then all of a sudden you hear a beep, 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 just pull back real quick and nobody had to tell you and it's fixed in a quarter of a second. So we're kind of, again, putting it all together. We'll kind of just go through the whole thing. So we picked up a probe. We're going to do our sanity check. Left is left. We're going to do our pre-scan. The vessel is staying in the middle of the screen. We found a nice spot. I'm going to have an entry site that's about the same distance from the top of the vessel back away from the probe. Give me that nice 45-degree angle. And have my needle here. I'm going to enter the skin, and then I'm going to drop the angle of my needle. Find the tip, nice bright white. I'm going to bring that needle back up so that I know exactly what I'm looking for. In general, it's not a good idea to make big angle changes like this once the needle is in the patient, especially deep. However, I say this is one exception because we're about to stick a scalpel right here, and any tissue damage we do is really kind of a moot point. All right, so we found a needle tip. We know exactly what it looks like. Now we're going to carefully march it down to the vessel. The distance I move the probe and the number of times that it takes for me to advance and get to the vessel really depends on how easy it is to see the needle tip. So we have our tissue indentation here. We're going to follow it down. We're going to find our needle tip. Now we're going to finish here with our vanishing bullseye. My hand has dropped all the way down, so now I feel confident in being able to advance that wire. So that's kind of the main things I wanted to talk about for the ultrasound-guided central line. I do want to go on just one more topic about dilation. I think this is also an area that people sometimes struggle with. So we'll start with a quick tip. Over-dilation and oozy central lines. If you've done many central lines, you may have run into where it just seems like after you put it in, that it just wants to bleed around your central line. The nurses are complaining because they always have to change their dressings, or just nothing sticks. It just always is just slowly oozing around that line. That's commonly caused by over-dilation or sinking that dilator too deep. The dilator is just for the skin and soft tissue, and it is wider than the catheter. So if you hub that dilator, all you're doing is punching a big hole in the vessel that you won't be able to plug with a catheter, and it's going to bleed. And some of these dilators, especially for like an HD length trialysis line, something like that, these dilators are dangerously long. You definitely do not want to hub a trialysis line dilator. So you really want to just go in far enough that the widest part of the dilator has separated the skin and really dilated that part. You may feel that there's a little bit of resistance, but as you get to that soft tissue, that it kind of becomes just a touch easier and then it goes more smoothly. Really, you shouldn't have to dilate past that. You don't even have to dilate into the vessel. You definitely don't want to get the dilator all the way into the vessel. So we want to dilate along the trajectory of our original needle. Our original needle trajectory. We made our skin neck, and now we're going to advance the dilator. You want to hold the dilator as you advance about a centimeter or so away from the skin, so you're feeding it in a little bit at a time. You don't want to hold it towards the opposite end, because as you're trying to advance, you can actually bend your dilator that way. I'm going to be holding close to the skin. And then we just want to advance it down. It should go fairly smoothly, maybe a little bit of resistance, but it should go smoothly. And again, just to remind you, the dilator itself is going to be usually at least 1 French larger than the catheter. So if you get the main width of the body of the dilator in the vessel, that hole is going to be bigger than the catheter, and it's just going to ooze everywhere, especially if the patient is coagulopathic. So at most, we're going to get the tip of that dilator in the vessel, and you really don't need to go that far. If you err a little bit on underdilating and have to dilate twice until you get a feel for it, that's okay. But you'll find that times where you have patients, with big lines, like uremic patients with uremic coagulopathy, if you can dilate those well, even though you're putting this fairly large dialysis line in this patient, it won't ooze around there because you'll have a nice seal. So let's talk about kinking the wire. If you haven't kinked a wire, then you probably haven't done that many central lines yet. But this is something that comes up not infrequently. And so it also can be a little bit frustrating because you'll say, oh, if there's resistance, you shouldn't advance anymore. But then maybe your staff comes in and pushes a little bit harder, then it goes smooth. And the next time you try it, you have some resistance, you push harder, and you kink the wire. So why does that happen? So kinking of the wire occurs when you try to dilate on a trajectory that's not the same as the original needle pass. So we look here. My original needle is about 45, but now I'm dilating at a shallower angle. And that's going to cause that kink in that wire. So how do you know if you just need to push harder when you're having a little resistance, or if you're going in the wrong trajectory? So one of the really useful things you can do is kind of floss the wire back and forth, which we'll show here, by moving that wire in and out of the dilator. That will tell you if you're on the right trajectory. So let's say you're trying to advance a dilator and you meet some resistance. If that wire goes in and out easily, even with that resistance, then if appropriate, you can maybe try just pushing just a touch harder to see if you can just get the width of the dilator through, and you just need to go a little bit more, or potentially making a slightly bigger skin nick. However, if you're meeting some resistance and then you try to move that wire in and out and it feels stuck or caught, don't push any harder, stop, and then bring your dilator, release pressure with the dilator, and then try to bring the angle usually up, because you probably are dilating too shallowly compared to that original needle pass. But long story short, if the wire goes in and out easily, then it's okay to push a little bit harder or potentially make a bigger skin nick. If the wire's caught, caution, stop, release pressure on that dilator, and try to make that angle closer to the original needle pass. So last little quick tip here is that if you're finding that kinking the wire is something that happens not infrequently with you, one thing you might try is holding the dilator as you're advancing, kind of like you're holding a pencil, and just feeding it forward with your thumb and your index finger. By holding it like a pencil, this is going to just naturally cause that dilator angle to be a little bit more steep and really more closely approximate the original needle angle. I think you'll find you'll have a lot fewer instances where you're having problems kinking the wire. All right, that's what I have. Thank you very much, and I hope this was helpful.